service delivery include delays and unpredictable disbursement, mainly because of delays from Treasury and sometimes even delays within the county Treasury before they get to the health facilities, and maybe from the health facility to where actually they're going to be spent. But we note that in that space, a few things are clear. For example, we still have poor budget execution. And that means we are not able to use all the money that is available to us as the health sector, despite the fact that it's not enough. And so even the little that we have, we are not fully able to utilize it. The second thing is the pending bills. Remember, whenever you have a pending bill, it's given the first priority before you start incurring your current bills. And so pending bills, again, affect the amount of money that are available. The second major problem is that the national PFM institutions adopted a controlling instead of a facilitative role in supporting counties for compliance. And that means that there's a greater need for county treasuries to then support to support the health sector in building capacity so that we could be able to ensure that some of these inefficiencies are dealt with. The third one is compliance with the PFM limits on budgeting. Remember that many times when we talk about the budget, we always start with certain rules and regulations on how we have to spend. For example, there is the 70-30. Thank you so much, our online viewers, and I hope that you can hear us. We're able to confirm that the online people can hear us? So some of the regulations that apply in PFM include, for example, we have a rule that says that 70%, no, yeah, 75% should go to should go to recurrent expenditure, and 35% would go to capital expenditure. So sometimes next of county governments, and we do need to have a lot of sensitization on the value and the importance of PFM, particularly to the health sector, to ensure that we can be able to utilize it to drive service delivery. So in addition, over the last 13 years of implementing devolution, another issue that has also been affecting service delivery has been the whole discussion on health facility autonomy. And this was occasioned by the fact that when we went through to devolution, the instructions to most of the health facilities was that any amount of money they earned should go to the county revenue fund rather than going directly to the health facilities. And that means it affected the amounts of resources and how they would be available to ensure that services then can be sorted out. The last thing is about the designation and the preparation of the entity reports by the accounting officers. And this again, while the law is clear on the designation for accounting officers, there has been a challenge between finance and health on who and how to account for those resources, almost getting to a point where each person says it's the other person's responsibility. And that means left most of the accounting officers within the health sector to play a more passive role rather than a more operational role when it comes to taking care of resources that are available within the health sector. Some of these issues that we have discussed here will form part of the discussions that will continue in this session, and we will be able to delve a little bit deeper into these activities. To be able to take us to the next point, I want to be able to invite Dr. Anita Musiega. She's a health economist from Kemley Wellcome Trust and a specialist in public financial management, particularly with a focus on the health sector. Please help welcome Dr. Anita Musiega.
Thank you. Good morning. Today morning I was thinking about this session and I told myself, we are in Homa Bay County. I personally live and work in Nairobi County. When I feel unwell when I'm in Nairobi County, I go to Aga Khan University Hospital to seek treatment. But I told myself, I think this conference had 11,000 delegates. God forbid anyone had an emergency medical situation here in Homa Bay County. Several kilometers away from Aga Khan University Hospital and several kilometers away from Nairobi Hospital, MP Shah, Kenyatta National Hospital, KUTTRH. Which facility do you think we should take anyone in this conference who has an emergency medical situation? As a nurse, the decision for me is very clear. If there's a patient requiring emergency medical services right now, because before AMREF, who are among the sponsors of this side event, show up with their evacuation, my decision would be to take that person, whoever they are, whether it's Anita, whether it's a governor, whether it's a senator, to Homa Bay County Teaching and Referral Hospital. Do you think Homa Bay County Teaching and Referral Hospital is staffed? Do you think they have the required medication? Do you think they have the equipment to handle a stroke, a cardiac arrest? Do you think you as an attender of an event in Homa Bay County is safe with the public facilities there? And this has happened before. We've seen governors going to local county hospital as the first point of contact. When you go to visit Diani on holiday, do you think Msambweni County Referral Hospital is equipped to handle your emergency before AMREF evacuates you? So today, we need to know, are the facilities staffed? Are they equipped? And can they handle the emergency of every Kenyan? And with me, I have a panel of experts who will help us answer that question. First, I have the honor of presenting to you Senator Catherine Muyeka Muma, who is a nominated senator in the Kenya Senate and a member of the Speaker's panel. She serves as the vice chairperson of the Senate Standing Committee on Devolution and Intergovernmental Relations, and is also a member of the Committees on Education and on Agriculture, Livestock and Fisheries. She's a passionate advocate for people-centered development. She brings decades of experience in governance, gender equality, public interest law to her legislative work. She's the vice chairperson of the Kenya Women Parliamentarians Association and a member of the Kenya Women Senators Association, where she plays a key role in advancing inclusive and gender-responsive policy. Senator Muma has previously served as a commissioner at the Kenya National Commission on Human Rights and the Commission for the Implementation of the Constitution, contributing significantly to rights-based reforms in governance and service delivery. Her commitment to health equity is also reflected in her work as a founder of the Adolescent Health and Rights Trust Africa and co-founder of KELIN. She continues to champion the integration of public finance management systems with equitable health service delivery in devolved units with a focus on marginalized populations. Ladies and gentlemen, Senator Catherine Muma. Next, who is going to tell us whether, when I'm on holiday in Diani, whether Msambweni County Referral Hospital is equipped to provide any emergency care that I may need. I have, ladies and gentlemen, the pleasure of inviting CPA Alex Onduko Thomas, who is the Chief Officer of Finance Caucus Chair. He currently serves as the Chief Officer of Finance and Economic Planning for Kwale County, a role he was appointed in 2013. He's a qualified accountant and a member of the ISPAC, the Institute of Certified Public Accountants of Kenya. He also holds a Master of Business Administration from Methodist University and has attended several management courses, such as the Senior Management course and the Strategic Leadership Development Program, both from the prestigious Kenya School of Government. CPA Onduko has vast experience in public finance management, having served the public service for over 25 years. He joined the public service in 1990 as an accountant at the County Council of Nakuru and rose to rank of town treasurer. He has served as a treasurer in the following defunct local authorities: Kajiado, Municipal Council of Migori, and Municipal Council of Busia. So he's all round. So ladies and gentlemen, Alex Onduko Thomas. I also have the pleasure of inviting Dr. Collins Masika, who is the med soup of my teaching and referral hospital at home, Vihiga County Referral Hospital, and who will be telling us today that if Anita is on holiday at home in December, whether Vihiga County Referral Hospital and the surrounding facilities are equipped to manage all emergencies. So Dr. Masika Collins was first posted in 2008 as a medical officer at the then Vihiga District Hospital, where he served diligently for 3 years. In recognition of his service, he was appointed as medical superintendent at Emuhaya Sub-County Hospital, a position he held for another 3 years. He holds a master's degree in health systems management, and his experience has strengthened his capacity in healthcare leadership and administration. He has also served as the Deputy Medical Superintendent at Vihiga County Referral Hospital. Subsequently, he was promoted to the position of Director of Medical Services, where he served with distinction until July 2025. He was then appointed as the Medical Superintendent of Vihiga Teaching and Referral Hospital, a role he currently holds. Dr. Collins is a dedicated and results-oriented healthcare professional, widely recognized for his teamwork, integrity, and commitment to the delivery of quality health services. Dr. Masika Collins, ladies and gentlemen. I also have the pleasure of inviting the guy who preceded me, who is a good friend of mine, and who has been working with in this PFM space with me for a while, and has also been a mentor. Boniface Mbudia is currently the Technical Director of Healthcare Financing at AMREF Health Africa. He has more than 25 years of experience in policy design and implementation on healthcare financing, focused on strengthening health systems in Africa and Asia as countries make progress towards the realization of UHC goals. He provides strategic and technical leadership on health financing to AMREF, country offices, and programs. In addition, Boniface has interest in PFM, supply chain financing arrangements, primary healthcare, health resource tracking, strategic health purchasing, and results-based financing. Boniface is regarded as a thought leader and is deeply involved in supporting governments, national and subnational, insurance agencies, and central medical stores. Previously at Thinkwell, where he served as the senior technical advisor, supporting the implementation of strategic health purchasing with a focus to primary healthcare in 5 countries, Kenya, Uganda, Burkina Faso, Philippines, and Indonesia. In addition, he has served as a consultant with the World Bank to provide support to subnational levels of government on planning, budgeting, and reporting. Boniface has a master's in public health from Moi University and has undertaken many professional courses on public finance management, among others. He's also widely published on different themes in healthcare financing with a focus on Africa and Asia, with more than 25 published papers. Ladies and gentlemen, Boniface Mbudia. Finally, I believe our last speaker is joining online. I have the pleasure of introducing a friend I have known for maybe 1-2 years right now, Dr. Kanyevu Muli. She's the Director of Audit, Office of the Auditor General, and is in charge of health, labor, and social protection. She's a seasoned audit and governance professional with over 20 years of experience in public sector auditing, financial oversight, and health systems accountability. Dorcas holds an MBA in finance, a master's in economic policy analysis, and is currently a PhD candidate in health economics at the University of Nairobi. She's also a certified public accountant and a certified information systems auditor. Her work supports evidence-based decision-making and promotes transparency, equity, and efficiency in health service delivery. She's committed to strengthening oversight mechanisms within devolved units and has contributed to shaping public discourse around governance in health. Dorcas is a member of ISPAC, AWAC, and the Women on Boards Network, and is passionate about aligning audit practices with the goals of UHC. Ladies and gentlemen, Dorcas Muli is joining online. So I will just start with a random question. Do you feel that Homa Bay County Referral Hospital can handle you in the event you have an emergency? And I will take a response from Dr. Collins, Alex, the Senator, and Boniface. A yes or no?
Hello, Colin. Hello? I think my response is no.
Morning. My response is yes, they can. My response is yes and no. It depends on the type of emergency. I'm sure Homa Bay referral can handle some things, and it may not be able to handle others.
My response would be yes, but it would depend. Yeah.
So, okay. Sorry. So I believe we are going to unpack why Dr. Collins, who is at the front line of service delivery, believes that the hospital cannot handle. Why Alex, who is in charge of financing at the county, believes that the county hospital, like his hospital, can handle. Why Senator Muma believes it's a yes or no. Why Boniface believes it's a yes or no. And for me, I think the answer for me would be most likely a no. So starting with Senator Muma. The role of Senate's oversight mandate is strengthening service delivery. What areas need to be strengthened in our public financial management system to enhance resource flow to county governments and therefore county health facilities?
Thank you very much. First, allow me to thank AMREF for organizing this event. I think it is so important, and I wish we had more people in here. For this reason, one, health is provided for as a right in our constitution. Secondly, the government has decided to implement something that is usually in everybody's manifesto as the vision for Kenya for health, which is universal healthcare. Now, universal healthcare means that every human being who is unwell in Kenya should be able to walk to a health facility and get services. People imagine that it means the services are free, but it actually means that we should be able to find the resource necessary to ensure that whether you are in Homa Bay or Garissa, you can walk to a health facility and get services. And the reason our constitution devolved health is precisely to ensure that there is access to those health services, whether you are in Isiolo, whether you are in Kakamega, whether you are in Nairobi. So for the Senate, we fight to ensure that we have more resources being devolved to county governments. That is the equitable share from the nationally collected revenue between national government and county governments. Thereafter, the devolved system requires that county assemblies would then be able, when counties are now having received their share, are defining how much goes to health, how much goes to water, how much goes to agriculture. They need to be able to make case for reasonable allocations for the delivery of the different services, including health. I would expect that one of the things they need to be aware about is that health is actually a life and death matter, comparable to roads. Roads are important, but health, in my view, I place it as the second human right to the right to life, because it actually means death and life, life and death. And therefore, it is one of the services that must be adequately supported in order for us to sustain life. So yes, the Senate works and is continuing to work hard to get counties to receive better equitable share. Currently, they're not receiving as best as we feel they should, largely because equitable share is determined on the basis of the last audited accounts. And for the past few years, the National Assembly has not considered the last audited accounts of the past 2 years. So it means we are actually, the counties receive funds based on accounts of the past 2 years instead of the current accounts. That means we are actually receiving less, counties are receiving less than they ought to. Secondly, despite the fact that health is devolved, national government is in charge of level 6 facilities, which are not many. They don't get to 10. The national government has a lot more money comparable to the combination of the 47 county governments. And I always make this joke, and I'm glad Oluga is not here, but somebody tell him. I call Afia House as the biggest hospital in Kenya. It has so many doctors who are not treating anybody, but getting a huge chunk of monies that should otherwise be delivering services. Don't quote me.
So, Senator, I agree with you on all counts that one, county governments are not receiving sufficient revenue. They are not receiving their fair share. And two, we need to do better in terms of distribution of resources, including human resources. CPA Alex Onduko, just picking up from where the senator left, maybe you can tell us what does it mean when you have less resources than what is entitled to you, and in that breath, since inception of devolution, counties adopted centralized PFM systems, which have often limited ability of frontline service delivery institutions to perform their function. What was the rationale for centralization?
Thank you so much, Annette. Maybe to pick up from where Honorable Senator has left, it's time we review the PFM Act, because it's still, it's now 10 years of devolution, and it still hangs on the 70-30 ratio, 30% for development. While from where counties are, we need to review the development ratio, because we've done a lot looking at the devolved functions. If it's in early childhood, it's in vocational training, we've done a lot that we can now not, we are not at the level of doing the facilities infrastructure again, but it's now about maintenance. And maintenance is about recurrent. So maybe, Senate, you need to look at how do you analyze the true status of devolution so that we can amend these ratios to allow for more resources to render services. Because we are still holding resources in development, in capital projects, while the service aspect is suffering. To come to your question on why the rationale of centralized financial reporting. One is complying with the provisions of the Public Finance Management Act. One of the provisions is counties need to have a single treasury account. And counties are running 2 single treasury accounts. One is for recurrent expenditure, the other is for development expenditure. So that can only be enhanced by compliance with the law. Secondly is from the inception, there was no capacity. And where counties are right now, they are more recruiting in more functions. I mean, more critical functions like health and education than in the service provision in the accountancy levels. So you find counties may not have enough staff in accounting, in procurement, in economic planning to send to every of the units. So that calls for centralization because of issues of capacity. Lastly is issues of, it's easier when you're doing auditing to audit at the central place than when you've devolved to all the departments as they have been established. So PFM is easier to follow up and reporting. Again, PFM has structures for reporting. So it's easier to report from the centralized position. And all the templates that have been made by be it the Accounting Standards Board, be it the Office of the Control of Budget, they are all centralized. So to comply to these entities and their requirements, it calls for a centralized authorization of PFM. Lastly, is also to safeguard resources. It's easier when one person is accountable. You are able to follow up on controls, internal controls, and also avoid on misuse of resources. So those are some of the issues that have still led to the rationale of a centralized system.
Thanks a lot, Alex. Dr. Collins, you've been in the system pre-devolution and post-devolution. Alex thinks there's a capacity issue. He thinks it's easier to manage resources when they are centralized. And he also thinks that there was a legal issue that impacted how resources went down to the facility level. From your experience as a medical frontline health provider, what has been your experience in managing health facilities in a centralized PFM environment where, as a doctor, you do not have access to resources?
Okay, thank you, colleagues. First of all, I would like to thank AMREF for giving us this podium to showcase and talk our experiences. And I hope whatever we share, in a way, should help in shaping policy in this country and elsewhere. I happen to have worked before the counties, that is when we had districts. And as a med sup then, we used to have our AIs straight from Afya House. It used to be some yellow paper. So you will know that in 3 months, your facilities are allocated 2 million, 3 million shillings. So it's upon you to liaise with the district accountants to spend. I happened also to be there when devolution came in and it was chaos, transiting from that system to devolution because there were new systems in place. I remember very well, Emuhaya, we had collected around some 1 million shillings or so. We were told to take that money to Vihiga. And where it went up to today, I don't know. So then from there, I think things have been coming up slowly, but I just quick first so that I don't spend a lot of time. The PFM Act is very well because resources are scarce. There's no day we shall have, like economists, a lot of resources. But remember, I think before I go there, we now from there now coming for the governors to accept that facilities really need resources, it was still a tug of war because they could not understand why health is that expensive. I remember there's a time a minister went and bought wooden beds and brought them. Then we were like, no. So it took time, and there's a lot. I like sharing what we've gone through. So it took time, and systems have had to come in place with a lot of struggles. But as per now, what is happening, like in Viga, the PFM goes on. We have to request monies from the treasury. But now, I would like to applaud our governor. We now normally have monthly meetings with the governor. And we shall share that, Governor, we are going to 1, 2, 3, 4. And I think as per now, they can feel why a health department or a hospital can need resources in a day, and it should be processed. So we are trying to go towards that. But colleagues, I can share with you that it was a real tug of war because our colleagues in accounting believe a hospital is like any other sector and it should take the 72 hours or so. But remember, you have a mother bleeding, you need some essential drugs. What will you do? So we are still talking policy, we are still advising them that, and we are going to, I don't know if it will contravene the PFM Act, but we are thinking, why can't we have super rights accountants in this facility so that if budgeting is done, planning is done, and if money is needed in 1 hour or 2 hours, it can be able to be done to save lives. I think that's my contribution.
Thank you, Dr. Collins. I have the Office of the Auditor General online. CPA Alex has said that they are concerned about reporting, whether facilities can be able to report. And Dorcas, if you can hear me and if you're able to speak, are there, the Senate passed the 2023 FIF Act alongside other UHC laws to provide legal framework for financial autonomy of health facilities. Based on your experience in auditing health facilities, what are the emerging challenges in implementing this law? Dorcas? Dorcas, maybe you can unmute. I don't know, or as we try and figure out the how Dorcas can be able to address Boniface from Senator Moma's position. Counties are not getting sufficient revenue. From Alex's position, there's still an accountability issues, capacity issues that need to be addressed. From Dr. Collins's position, PFM systems, the improvements have seen improvements in service delivery. What do we do to ensure that we get more resources? We address the accountability issues and we actually translate this to service delivery.
Thank you. Thank you so much, Anita. And it's true that the amounts of money going to the health sector are still not adequate. And I would start by just giving a bit of details. When you analyze the amount of money going to the counties, it ranges between 1,800 and 3,000 shillings per person per year. To be honest, what can you buy with 3,000 shillings? It's probably a bag of maize. Or half a bag, right? But that's the amount of money that we have allocated to the health sector that's supposed to give services to all people according to their various needs without discriminating anyone. And that means that we still need to continue discussing about ways we can be able to allocate more resources to the health sector. The second thing that's also important for our consideration is to note that counties heavily depend on national treasury for resourcing. And that means that if there is any alterations on the flow of resources from treasury, then facilities are left without any sources, any funds with them, because the own source revenue for counties is about 10%. And so 90% comes from the national treasury. And so if the national treasury delays the funds allocated to counties for 7 months, 8 months, or even 1 year, let's look at it from the most extreme. It then means that we have many months of no money for running the health facilities. And then thirdly, this own source revenue that's been collected is still too little. Compared to the amounts of money allocated to the health sector, it's less than 15%. 15%. And that means, technically, the amount of money collected by facilities can technically run the health facility for 1 month or thereabouts. And that means we have almost 11 months that will be uncertain because of the challenges of the flow of funds. Now, having said that, it is important for us to remember that it takes resources to deliver quality health services. And it's good that we look for synergies that we can be able to put in between Treasury and the health sector so that the challenges that affect the flow of funds can be resolved in a more sustainable way. Otherwise, when the discussion still remains of us versus them, then we are not able to sort out the issues that affect the flow of funds to the health facilities. In terms of health services, it's good to note that when money is not available, it has negative effects on service delivery, because let's assume that a mother had come for family planning, and for one reason or another, we don't have inputs or the things that we need to be able to offer the family planning. Will that mother come again next month? Will that mother come another day? And so you see, the failure to allocate adequate resources to our health facilities also affects the health-seeking behavior of our communities. Currently, in our country, we would say that on outpatient, generally across the country, an individual goes to a health facility 1.2 visits per year per person. And that means that we have a very low encounter between the communities and the health facilities. And that means that the opportunities to be able to diagnose other diseases then also becomes much narrower. And that's why we need to be able to address more sustainably the issues of financing health facilities in our country.
Senator Muma, as a Senate, you're charged with the responsibility for oversight. That is to mean that you are charged with the responsibility of ensuring that county governments are using our resources as Kenyans optimally to deliver services.
To that question, first I'd like to just mention that when we say counties don't get enough money for health or don't plan enough money for health, the question would be, what would be enough money for health? So the first thing I would want us to get to basics about is the kind of governance system that is required, whether you are in Kenyatta National Hospital or whether you are in a level 3 facility, to ensure that you are delivering services. Yesterday, the Prime Cabinet Secretary talked about the need for county governments to establish their planning and statistical institutions. And I would want to ask, how many of the counties actually are taking seriously their planning and statistical departments in order to be able to say that the needs of the people in Vihiga when it comes to health are the following in terms of breakdown of the disease types, of the various needs that we need to take care of, and therefore require so much in finances in order for us to deliver. I would also want, even before I answer, to again project to one of the presentations that was made by Governor for Murang'a. What did Governor for Murang'a present? A system that is actually able to enable him to know what's happening in a hospital, whether he is in Homa Bay or in the USA. So is it that we need more accountants, or we just need a transparent and accountable, simple system that ensures everybody to account? Number two, I was again on another panel where we were told by a governor of a woman who was nearly lost because the only service medical practitioner was attending to a surgery in his private hospital instead of being at the public service. So what am I trying to tell you? That service delivery will take a combination of funds, a combination of transparent and accountable service delivery systems, a combination of professional service delivery by those charged with it, and in where I come from, I call that a people-centered rights approach to service delivery. If we do that, it means we will be able to decide that in Wajir, we have analyzed our health profile and situation, and what we need is the following to deliver. The governor and his team will then be able to say, from the resources that we have, we should be able to deploy so much in order to deliver these services. And if we don't have enough, we should, during the intergovernmental conversations with the national government, negotiate for conditional grants or for all of this. And when we come to Senate, which negotiates for the equitable share, and as I have told you, up to now we are still negotiating for more. We are saying it's not enough. We are asking National Assembly, can you clear the audits in order for counties to get more? We are asking national government, can you release the functions to counties and give them the funds for the functions you are holding? We are trying to tell national government, the amounts you are holding on health are much higher than counties, and clearly there is something wrong with that. We are also trying to tell counties, and we evaluate, by the way, one of the things my committee has been evaluating lately is to find out why many counties are not going, are not reaching the 30% recurrent. Actually, many are over 70% recurrent. Of course, we had an issue where they were inherited in 2013, all the workforce, including the local workforce, and they were not allowed to structure at that time. But we also have had every governor coming in with more people, employing more people, advisors to governors, advisors to CECs, sometimes are more than the public service. In fact, there are 2 counties we looked at which has employed over 30 chief officers. We don't know why. And it has over 30 advisors when the cabinet is around 12. So we are looking at those things and actually trying to tell counties, this is wasteful expenditure when functions like health require money because they're about life and death. I'm also of the view, have always been of the view that when it comes to health function, services by specialized workers like doctors, nurses, should actually be factored as development expenditure, because it is at the core of the primary service that is delivered within health facilities. It is a conversation that is going on, and I don't know how far that has moved, but there is a lot more. It is not just about money. It's about transparency, accountability, and good governance.
Thank you. Thanks a lot, Senator, and I'm glad you're an advocate for transparency, accountability, people-centered services. I'll take it to Dorcas Muli. Maybe you can tell us about accountability in health facilities. Have you been able to audit these facilities, and what are some of the emerging challenges in implementing the FIF law, Dorcas?
You can confirm whether I'm audible?
Yes, Dorcas, you're audible.
Yes, Doctor, you're audible. Thank you so much, and apologies, I was not able to come. Sorry? Yes, Dorcas? Maybe I can put on my video shortly, then I switch it off. And first is to apologize that I was not to be there physically due to, I think, the same things that we are discussing about scarcity and choice. We were not able to get transport this week to Homa Bay, but it's understandable. So as introduced, I'm a Director of Audit at the Office of the Auditor General in charge of the health sector, and I'll be able to respond to the question raised. I like looking at the health sector at a global perspective. Allow me to switch off the video because of the network. Sorry, I was saying I like looking at the health sector at a global space. From where I see it, I'm able to see the health sector from the national level at the county level. So just as an introduction, just to give you a picture, then I go straight to the challenges, is that from the audit perspective, we audit the Ministry of Health, the 2 state departments, and the agencies under the state departments. There are around 63 entities under the Ministry of Health. Then we also audit the level 4, level 5, and level 6 hospitals, and we also go to the facilities. So I'll be talking about some of the challenges that we have seen. Of course, this is not a meeting to discuss audit findings, but just to look at the challenges that we've seen in implementation of the FIF Act. And for the facilities that we've been able to audit and to review, we've seen challenges in terms of the ability to record and to maintain proper records for revenue received. And it's interesting because this cuts across the on-source revenue and also revenue that is received from the central government through the county governments. And one of the challenges that we've seen is in the oversight component, the staffing, the management, and also the governance level. And the governance level is has to do with the board for the independent entities. I think the expectation is that the entities are supposed to have a board that provides oversight. Then they're supposed to have staff. The expectation is that they should have enough staff to manage the resources within the facilities. Then they're also expected to have experienced staff who are able to do that. What we've seen is that some of the facilities, and it is understandable, but I think it's upon the players in the space to ensure even for the facilities that do not have enough staff, there's oversight from a central space. A good example is where you go to a facility that is being served by only one officer. It's the same person who is maintaining the records. It's the same person who is offering the treatment. It's the same person who is giving the services that are required. But we've also seen undisclosed revenues where they receive revenues but they do not record. And that also adds to the preparation of financial statements. We've seen instances where facilities are not able to prepare financial statements, but they're relying on one person for different entities. Sometimes we're able to notice that where the same name cuts across different health facilities. The issue of delays and unpredictability in receipt of resources, that is very common and affects implementation of what is planned at the facility level. And this cuts across collection of all sources of revenue, reimbursements from the social insurance. It will be interesting to see the outcome from the digitization and the current laws on social insurance. And we don't have the findings for that. Maybe in the coming year, we should be able to see how that will play out and how different that will be from the reimbursement from NHIF. We know counties and specifically facilities, some of them have not received the reimbursements that are due from the NHIF that was replaced by SHA. Then the other thing is I talked about institutional capacity, and I think I would also want to emphasize again when it comes to having internal checks and balances. We talk about internal audit oversight. Most of the time, it may not be possible for all the facilities to have their own internal audit, but the counties should ensure that there is a way of checks and balances when it comes to the internal control environment of the different facilities. Again, the requirement when there is a board is that there should be an audit committee. We've seen a challenge where some of them, they don't have audit committees. It may not be to the granular, the smaller facilities, but at least at the level 4, level 5, at least having an audit committee to oversight the internal audit function can add value to the internal control and environment. I've already talked about the inadequacies in staffing, and I think this cuts across. I've seen for some of the counties, I don't know how practical it is, where they have roving staff who can support one facility and another, and especially for the shared resources like accountants and people that can support the internal control environment. Of course, we also have the challenge of mismanagement and wastage. And we've also seen a lot of incomplete projects. And you see, when those projects are completed, they are prioritized and they are completed, of course, they will build into service delivery. Then we've also seen limited capacity for revenue tracking. And most of it is where records are maintained manually. There are no systems of tracking and collection of revenue. It will be interesting to see how the digital health digitization will support that component. We are not sure how long that will take to be able to support all the facilities, but we expect maybe there'll be a change in terms of when digitization cuts across all the counties. With manual records, we find a lot of errors, a lot of omissions, and it becomes difficult even to say how much revenue was collected. We've also seen inadequacies in budgeting where some components are not budgeted for, others are budgeted for, but they are not implemented in line with the budget. And the other thing is, of course, somebody already mentioned about delays in exchequer releases. Sometimes it takes time for money to be received at the counties and at the facilities for implementation of programs. Other times the money is allocated, but again, being able to receive the money becomes a challenge. Sometimes you're not sure whether you'll be able to receive the money that was allocated that has not been received at the end of the year. So we cannot overemphasize insufficient resources that are persistent in the facilities and in the counties. I think I can pause at that. Thank you.
Thanks a lot, Dorcas, for the insightful comments. At the top of my mind, I remember that you said the boards are important. So health facility autonomy is embedded in bringing services and decision-making closer to the people. And a core part of it is having a board and committee that is
Let me confirm I was not speaking to myself.
Oh, no. Oh, so yes, Dorcas. I had muted on my side. Yeah, so we could hear you very well. So Dorcas, I was just summarizing what there's an echo. It's now resolved. Okay. So Dorcas, I was just summarizing the key points, and I was saying that, like you said, the boards and committees are important because one of the roles of facility autonomy is that it's embedded in community participation, having community representatives in committees and boards, and them being part of facility decision making. And one of the other things you've said is that reporting is mandatory, capacity is mandatory, and you cannot have one facility served facility manager and you charge them with the responsibility of everything. So that is going to bring challenges. And I'm sure Alex shares a lot of your insights including you raised issues to do with misappropriation, which must be addressed for FIF to fully function and for service delivery, for FIF funds to actually impact on people. So Alex, finally to you, as I wrap it up, I beg your indulgence. We started late, so in another 7 minutes, I should have wrapped this up. So Alex, maybe finally to you, with the enactment of the 2023 FIF Act and the policy imperative for health facility financial autonomy, what should counties do to ensure that the spirit of FIF is fully implemented? And I'll put you to task, because FIF is just not about what facilities collect in their own source revenues and what they raise. It's also about allocations from the county to ensure that the facilities are fully functioning. So what should counties do to ensure that the spirit of FIF is fully implemented?
Thank you, Annette. For FIF to fully work, is one critical thing is to build capacity for the health staff and all those committees that have been established, because they are key in running FIF. Then two, the Kwale example is we allow facilities to retain 100% of their collection. And in their budgeting, we have excluded from it money for drugs, for reagents, and non-farms that is provided for from the exchequer release, so that the facilities can be able to run with the small issues that they can do, and a little budget on drugs, so that before the stock comes, they are able to buy the small supplies that they need. The other issue is what we need to do is to amend the Public Procurement and Asset Disposal Act, so that it allows for facilities to procure from within. Because again, one challenge they have is, yes, they have money, but now they have to follow a rigid procurement process. And if you want something to save a patient, you can only run to the nearest chemist that is around. So again, maybe Senator, that is one area we need to look at, amend the Public Procurement and Asset Disposal Act, especially for health, to allow them to do direct procurement, other than follow the rigid requisition and that to offer efficient service. Secondly, again, this is a Senate that we need to look at. Since training is a national government function, doctors and health personnel have no training in management and accounting. This is one area we need to find that there is a unit, as doctors train in management. There's a unit, something that involves on human resource management. There's basic unit in accounting, because now we are giving them functions that they are not basically trained to do. So I think Senate, we need to pick up and look at the curriculum for training for doctors, for nurses, for clinical officers, to equip them with this. Lastly is the costing of services. It's a big challenge we have that our services in health are not costed. The cost we are buying drugs from KEMSA is not the very same cost we are charging patients. And they cannot break even. So we need to find for a standardized way that we can cost our services, so that even as FIF works, it is able to compensate for the services that they are rendering. Thank you.
I know, leading on to the SHA regulations and the benefit package, there was a costing process that was undertaken, especially for PHC facilities, and there's a planned costing process for level 4 and 5 facilities. I don't know if government is the same government that can share information across, but to you, Dr. Collins, CPA Alex has raised a number of issues, feeling that the Public Procurement Act should be improved to allow you people to, your teams as health facility managers, to be able to procure quickly. they feel that there's leadership. She feels that there's a leadership and management training that is required for facility managers to be able to deliver this FIF so that it works fully for us. You sit at the Center of Delivery of PHC and UHC. UHC is actually, in fact, delivered at the health facility level. The rest is for supporting roles from the county finance, supporting roles from the Senate, supporting roles from development partners like Boniface, supporting roles from researchers like Anita, but it's at the health facility that UHC and policies are actually implemented together with at the community level, which is another level of health service provision. So what should counties do to strengthen health service delivery to realize the big ambitions we have as a country for UHC?
Okay. It seems broad. Yes. Okay, the portfolio seems broad, but I think I will attach it in, I will try to respond. Hello? Okay. I think I'll try to respond where I can and that it can be helped by my colleagues. First of all, I would like to echo what my colleague has said, and I fully agree with him. The issues of facilities retaining 100% of what they collect. And I wish that if that's happening in Kwale, they retain 100%, then the counties supporting the major procurements like the drugs, the non-farms and group. If that happens like to most facilities, I think we'll have tools for us delivering service to our people. Now, on UHC, I don't know if that is where we are getting, what we shall do to get to UHC. I would like to showcase our situation in Vihiga County. We are privileged to be fully covered by CHPs at the community. So those CHPs are overseeing the households down there. They can give us the needs, and I think AMREF was also part of the partners that really helped us in this endeavor. So those CHPs can give us the needs of the common person. When we're having those forums with them, we can now plan knowing what, sometimes you can plan, and maybe I'm planning for us only panelists. We are only procuring drugs for us only panelists, not knowing what's on the ground, what are the higher percentage. So we are privileged to know that when we are planning with our meager resources, we know Vihiga County, maybe Tungiasis is a bigger problem than NCDs. So when we are planning, at least we try and know what is on the ground. The other thing is there's something I would like to differ a bit with him about direct procurement. Our people who are giving our services locally, unfortunately, there's an issue with standards. I don't want to showcase some of the examples, but I've had some deliveries that they enter a facility and they are rejected upfront. And these are millions and millions of shillings. Then it comes to audit queries. So we don't have the capacity to locally process. But I think if we had good planning and forecasting, so that we don't wait for things to get depleted is when we start running around buying, I think that could be a good way of using standardized ways of procurement, getting the best services. But still, I think we shall need to have more training, and I've been trying to talk to my procurement people so that they are part of us. First of all, it was like it's silos. The procurement and finance, it's silos, then the health sector, main service deliveries are silos on their own. So if we have a way so that we train together and understand why if I'm asking for a certain drug, it needs to be done faster, so that the procurement person may delay buying cement for the constructions going on and prioritize a file that is going to buy essential drugs. It will be good for us. Yes. I might be amorphous, but I think maybe I've said something. Thank you.
So maybe I may request for support from Catherine, because I'm going to take comments and questions from the audience. If you have any comment or question directed to anyone, I will be happy to take that. And and as you raise the question, I will ask you as a participant, what in your opinion should Homa Bay County do to ensure that the next time they host the event, everyone here is certain that they can provide healthcare services? What can we do to ensure that our public finance resources translates to service delivery? Please raise your hands, and while the mic comes to you, I will take another comment from Senator Muma.
Thank you. Now, I just wanted to make the comment that health is not just about facility-based health. As I said earlier, we need to do a holistic analysis as counties, as a country, on what health entails and what inputs we need to put in order for us to deliver on this. And then everybody, including citizens, have a responsibility to play in order for our health service delivery to work well. One, how much, I didn't hear us speak about preventive and promotive health. Next time we need to find out how do we discuss this and also make the linkage that if we do preventive and promotive, we reduce the stress on facilities in a very profound way. Secondly, when we are talking, something important I want to raise, when we are talking about oversight, the county assemblies are the primary oversight institution for county executives. But it is only day before yesterday that the president assented to the law that is actually giving independence to the county assemblies. You will find that county assemblies have not been able to raise concerns with county executives because they would actually be put in the spot. The finances of county assemblies have been run by the county treasuries. So the county assemblies that have in the past attempted to raise concerns have usually been punished by the executive. I can give you an example of a county which I will not name, where if you discuss issues as an MCA, if you discuss issues that criticize the governor, the very next day the speaker is asked to reshuffle the committees. And that county assembly has been left to singing praises of the governor and indicating on how the governor should get a 2-term. So when you're talking about oversight next time, I think it will be good for us to be able to bring county assembly executive representatives to find out how are they carrying out their job in terms of appropriating budgets in counties, holding governors accountable on what they ought to be doing, and so on. And then the issue of training, I don't think we need a law. National government has the responsibility to provide technical support, but county governments, nothing has stopped county governments from providing training to its health facility heads to deliver on the services that they can't tell you there is no law that stops us from training the facility superintendents from being trained in management. That is an excuse that you cannot say because there is a law, no law, then that cannot happen. So what we need, as I said earlier, first, let us plan this function properly. Let us look for the data per county. Let us plan with that data. Let us ensure we have adequate human resource. We may not get it in a day. This is a progressive right, but let us, even while we have the limited, let us apply the key principles of people-centered, transparent, and accountable governance. Whether you are an MCA, whether you are a senator, whether you are a governor, whether you are a worker, doctor, a nurse, and so on. And for the citizens, we also need to understand, in my view, we no longer have NHIF. So even as you listen to politicians telling you SHA is working or SHA is not working, you need to realize when you get sick, you'll have to go to a hospital. So my take is, first, register and join and pay SHIF. And number two, let us also be honest. We have many Kenyans who are joining and not paying anything even when they are capable. We have those who are not able to pay, but we have many who are actually lying in terms of their information and not paying. UHC is not free. It has to be paid for from somewhere. President Ruto does not have money in his account as President Ruto to pay the health. It is actually the people of Kenya who pay. And the concept of UHC is that everybody who is able to pay their level, and we carry everybody's burden. So if you are able to pay and you're cheating on the amount you should be paying, what is the difference between you and the person who is stealing, who you are saying is corrupt and should go? So we all have responsibility in order to deliver health.
Thanks very much. So as Senator Muma says, something that I'm also a firm believer in, we all have responsibilities. Even as the public, you have the responsibility for public participation and public accountability, and the responsibility to actually register and pay your part. The county governments have the responsibility of using the funds available and appropriately and efficiently. The Senate have the responsibility to legislate, and everyone has their responsibility. And as Kenyans, we all ought to play our roles effectively to make sure the health system works. So I will take a one-word comment from all the panelists to wrap up before we have someone who will give us the take-home messages and way forward. So one sentence, one word. Somehow these public funds have to find a way to make sure health services are delivered. As a country, we have significantly increased the amount of funding we are spending on healthcare over the years, and right now I think we are at above $100 per person per year. That is a lot of billions of shillings. Right now, I think around 500 B together with the private sector spent on health yearly. For that share of public funds, how do we make sure that the next time Anita is in Homa Bay or Kwale or any other person in this panel, that you are guaranteed access to healthcare in an emergency? And this is when it relates to public funds. I'll take from Boniface, then I'll take from Dr. Collins, then I'll take from Alex, and I will wrap it up with Senator Muma in one sentence.
So I think one important thing for us to remember is that we must make health systems work. Because if any one of us was going to get an emergency here, then Homa Bay County Referral becomes the place where we get the services. So we should make the system for all of us, not for some of us. And that way, PFM and all these other different systems that we are talking about should work to help deliver better health services.
Yes, I hope my mic is working. I think policy, planning, effective use of our resources will get us somewhere in enabling our clients get the services they need. Just to add on it, also our health workers need some patriotism. Training has made people a bit inhuman, but also let's have some training that makes our health workers have some humanity in them when treating their fellow humans. Thank you.
My take would be that one, effective budgeting. Now that we have resources at the facility level, how do they prioritize their budgeting? If that is done, access to health will be very easy, because they will be procuring what is a priority and what is of use to the facility. Secondly, I agree with my brother here that a lot of challenges in health are caused by the health staff themselves. If they would be keen and want to serve the citizens. Because one role of devolution was for us to serve our own citizens. So if they are keen on that, then we'll eliminate 30% of the problems we have, stealing of drugs and facilities and equipments. That we would see is lack of patriotism and care for service. Thank you.
Oh, yeah, it's me.
So I'll take Dorcas' final comments. Dorcas, this is Anita. I will take your final comments before we take Senator Muma's. Apologies.
Is the players in the health sector should be more cohesive and laws. I think sometimes they of doubt on whether one party is for the other. So in one sentence, I think we need more cohesion among the players in the health sector. Thank you.
Thanks. Thanks, Dorcas. More cohesion among players in the health sector. Now I will take a final statement from Senator Muma.
If there is the only one thing that we should have political convergence on is positive health service delivery, because it can only be second to support of life. Thank you.
So it's cohesion, it's positive health service delivery. For me, I will say, I think each of us as a citizen needs to play their role. So as I live here today, and as I hand it over to Gilbert to wrap this for us, I am hoping that Senator Muma will be able to push the national government to allocate sufficient resources to counties. I am hoping that when those resources get to the county, that Alex and the other Alexes in the 47 counties will be able to allocate these resources sufficiently, including to health. And when these resources are allocated to health, I'm hoping that chief officers like within health, like the chief officer, Homa Bay, my friend, Dr. Kevin Dan Osuri, will be able to ensure that these resources are used appropriately within health, to make sure that Dr. Collins is able to budget for these resources appropriately, to equip Vihiga County Referral Hospital, Homa Bay County Referral Hospital, and that the committees who are the public will be able to participate in this decision making. I am hoping that Vihiga County Referral Hospital, together with CHPs and the community, to be able to provide services, including preventive services. And I hope that by the time Dorcas Muli from the Office of the Auditor General, by the time Senator Muma, by the time the County Assembly is providing oversight, then they will say that Kenyans received services and that we have increased our life expectancy, and every individual Kenyan who needed emergency care got emergency care. Ladies and gentlemen, may I have Gilbert for the wrap-up? My panel, I will request that you remain there, because I think after Gilbert, we will have a small token for you. Thank you.
Thanks a lot to the panelists for this very informative conversation. First, I'd like just one to the organizers of this event, just thinking through. There's no way you can be able to discuss health without the equation of financing health. It's one of the key pillars. You can talk everything else, but if there are no resources, it's like the engine. And therefore this conversation, and therefore this conversation, excuse me, the code, what am I supposed to do with this? I'm told that before I continue, you need to scan and register. So health financing is a key pillar that has been ignored for quite some time. We have focused more on service delivery, but delivering services, and for me, this country has made a lot of strides. First, I want to thank the legislative arm of government for being able to give us a legislative framework for us to be able to operate. Otherwise, we have been having a very weak legislative environment, and just passing the act, the FIF Act, has been a game changer for this particular country as we strengthen health systems. But again, the thing here is that as we do that, the process of operationalizing that act, we really appreciate that the regulations that have been able to be put together to ensure that the health financing is being operationalized, including developing manuals for training the healthcare workers or the people who are going to use the finances. I will say the health space has two equations. The equation has two elements. One, mobilize the resources for the resources to be available. But number two is to use those resources. Once we address those two equations, I think we have now addressed more on mobilizing the resources. It will never be enough. The resources will never be enough. But the little that we have, how do we efficiently use those resources to be able to purchase health? We need to purchase health. Whether you talk it human resource, whether you are talking about supplies, whether you are talking about lab reagents, it is about purchasing health. And therefore, how can we be able to have systems that are efficient, that we don't now again to relook at the Senate to come and oversight us to purchase? They have given us the framework. So this conversation now, we need to move on the efficient use of the resources that have been available to us. I think, Madam Senator, one of the requests that we want to put on your table as we move forward is that there is a lot of conversation around SHA, especially for money for the insured. But then primary health care, level 1, 2, 3, services that are funded through exchequer. The question here is that funds adequate? If it's not adequate, are we still looking that there is a donor somewhere who is going to give us money? No. We need to mobilize the resource. And my appeal is we need to relook at the excise policy, especially the excise policy on the sin tax. I think there are 3 countries or 4 countries which have been able to meet in Africa, which have been able to meet the World WHO standards of meeting the sin tax. Kenya, we are still far. The more we consume alcohol, we produce cigarettes and sugar-based beverages, which are bringing us more non-communicable diseases. They need to pay because they are the ones who are tailing us back to the health facilities. We need to tax them. And we'll be addressing 2 things: mobilizing resources from the tin tax, and then also reducing the consumption of the harmful products. So thank you very much. I know all the conversation that have come from this conversation, we are going to use them to be able to drive the strengthening of the health financing pillar for this particular country. Asanteni sana, and God bless you all.
Before you go and sit, maybe you come and help me. Yes, I will have the gifts for my panelists, helped by Gilbert and helped by Miss Abigail Osendi. First, I will have Boniface. Boniface, I will have you first. And Gilbert, okay. Oh, sorry. We have to sort some things out.
Just ensure it has something inside.
Yes.
So that it's not just a bag.
We have to. Okay. Maybe, Catherine, you can sort that out for us. Okay.
What is...
Oh, yes. So this is for Collins. Then Alex. Boni kwanza. Yes. So we'll give this for Boniface. Yeah. So Boniface first, and then Dr. Collins will be given by Abigail. Thank you. Please, a round of applause for Dr. Collins. And then he will give Alex a round of applause for Alex. Thanks a lot, Alex. We are counting on you to get the chief officers to lead us in the right direction. And then Abigail from Vihiga County will give Senator Muma a round of applause for Senator Muma. We are counting on her to make sure the national government allocates sufficient resources. Thank you very much, ladies and gentlemen. Maybe we'll all come together for a final photo. So thank you very much, ladies and gentlemen. Thank you very much, the online viewers. Thank you very much, the online panelists. We will send your gift to Nairobi. Thank you very much, ladies and gentlemen, and have a good rest of your day. Thank you.